Hi everyone, my name is Leonard and today I'll be demonstrating fundamental airway management techniques. In particular, I'll be showing you strategies to maximize airway patency, as well as how to perform bag valve mask ventilation. To start off, let's assume we have arrived on the scene of an unconscious patient who is lying supine with a slight snore. The immediate concern here is the lack of a patent airway due to soft tissue obstruction. It is important to understand that patients who are unconscious often lose muscle tone in their upper airway. Evidence demonstrates that this can lead to obstruction by three main structures. Number one is the tongue. As the mandible falls backwards, the tongue is displaced posteriorly, causing obstruction at the level of the oropharynx. Number two is epiglottis. As the hyoid bone retracts, the epiglottis can cause obstruction against the laryngopharynx. And number three is the soft palate, which can push up against the back of the nasopharynx. So how can we fix these upper airway obstructions? We can use a combination of positioning, airway manoeuvres, and airway adjuncts. Let's look at positioning first. To optimize the patient's position, we need to start off by bringing the external auditory meatus in line with the sternal notch. In normal sized individuals, this can often be achieved by placing the patient into the sniffing position. The sniffing position consists of neck flexion with head extension. Neck flexion is achieved by placing folded towels or blankets under the patient's head. Head extension is accomplished by tilting the head back at the atlanto-occipital joint. In obese individuals, the sniffing position will often not be enough to raise the external auditory meatus to the level of the sternal notch. In this case, ramping the patient using blankets and pillows behind the torso, shoulders, and neck may be required. So what are the benefits of placing the patient into a sniffing or ramping position? Firstly, it can dramatically improve airway patency. Even just the act of tilting the head back causes a hyoid bone and epiglottis to be lifted away from the posterior pharynx. Secondly, it decreases airway resistance and therefore improves airflow. And thirdly, it significantly improves laryngeal view during direct laryngoscopy by bringing the oral, pharyngeal, and laryngeal axes into close alignment. Within the pre-hospital environment, this is particularly important if the patient goes on to be intubated. Now, although the sniffing and ramping position optimizes upper airway patency, we can make further adjustments to optimize the lower airways. If the patient is able to be moved onto the stretcher or is on some other adjustable backrest, it is helpful to raise the patient into a more semi-recumbent position. A 2018 study found that compared to lying supine, patients who were positioned to at least a 30-degree incline had a larger functional residual capacity, improved lung compliance, and decreased airway resistance. To conclude the discussion on positioning, it is important to note a couple of safety points. Firstly, the strategies I have described do not apply to patients with suspected C-spine injuries. In these cases, the patient should be kept in a neutral position with only minor padding placed beneath the head. Secondly, the lateral or recovery position should also be considered for patients who have evidence of vomiting, bleeding, or excessive secretions in order to prevent aspiration. In addition to simple head and neck positioning, specific airway maneuvers are also useful in reducing soft tissue airway obstructions. Various individual maneuvers, as well as combinations of maneuvers, exist, but one which is used across various ambulance services is the triple airway maneuver. Although minor variations exist between ambulance services regarding what makes up the triple airway maneuver, most authors describe it as comprising of head tilt, jaw thrust, and opening the mouth. So let's go through it. After ensuring that you have taken appropriate safety precautions, including PPE, the first maneuver is to tilt the head back. As previously discussed, tilting the head pulls the laryngeal structures away from the posterior pharynx and assists in opening the airway. The second maneuver is jaw thrust. To do this, grip the angles of the mandible with both hands and displace the jaw forward. Because the tongue is attached to the jaw, this will subsequently lift the tongue away from the posterior pharynx and improve airway patency. The third and final step is to simply keep the mouth open. This is essential if the soft palate is occluding the nasopharynx, leaving the oral cavity as the only means of ventilation. It is important to point out that although the triple airway maneuver is indicated for patients who require airway management, Its use is not recommended in patients with possible C-spine injuries, and as a result, it has been listed as a precaution by both AV and the QAS. For patients with potential C-spine injury, the head and neck should remain in a neutral position. Only jaw thrusts and mouth opening should be performed. After a patient's airway is cleared of soft tissue obstructions using manual techniques, it is important to ensure that it remains patent and does not re-occlude. This is where airway adjuncts, such as an oropharyngeal or nasopharyngeal airway, are useful. A properly fitted OPA should prevent the tongue from falling back against the posterior pharynx. It also assists in keeping the mouth open. A properly placed NPA also has the added benefit of reducing the risk of the soft palate from pushing up against the back of the nasopharynx. After learning about how to maintain a patent airway, let's now talk about how to properly ventilate a patient using a bag valve mask. To start with, let's run through some of the basics and setup. A bag valve mask is indicated in a patient with apnea or hypoventilation. Although there are no specific contraindications or precautions for the use of a BVM itself, there are some complications to be aware of. It can cause gastric inflation, pulmonary barotrauma, and even cardiovascular compromise, such as hypotension. In Ambulance Victoria, we currently use the Ambu Spur 2 BVM. A few points to highlight about this equipment. The compression bag itself holds just over 1500 ml of air and will therefore only need a third of its contents to be squeezed to generate a normal tidal volume of 500 ml. The Ambu BVM has a single shutter valve system, unlike the traditional duckbill valve in most BVMs. Nevertheless, a spontaneously ventilating patient will still need to generate 5 cm of H2O worth of inspiratory pressure to allow inspiration of new air. Therefore, in patients with very low spontaneous tidal volumes, it is still important to squeeze the bag. The first step to creating a good seal is by choosing the correct size mask. The narrow end of the mask should cover the bridge of the nose, while the lower end of the mask should sit between the bottom lip and chin. If you're performing single person BVM, you adopt a CE position with the hand on the mask. That is, your index finger and thumb form a C shape on the top part of the mask, while your middle, ring and little fingers are placed on the mandible. The single person approach to BVM ventilation is not ideal, as forming an adequate seal without any leak is very difficult. Preferably, you'll adopt a two-person approach to BVM ventilation. This will allow one person to be completely dedicated to maintaining a good seal. There are two types of hand position commonly adopted. The first is the CE position again, this time with both hands. It is possible to get a good seal, however, it is also easy to become fatigued with this approach. A more effective hand grip is the thumbs down approach or thenar eminence grip. To do this, place the thumbs and thenar eminence of both hands on the top of the mask. This allows the remaining fingers to grip the mandible and provide jaw thrust if necessary. Be careful to not push the mask into the face, but rather lift the face into the mask. Overall, the thumbs down method provides a better grip, is less fatiguing, and delivers greater control of the mandible. Also, just remember to keep the fingers on the mandible and avoid compressing the soft structures beneath, as this may obstruct the upper airway again. When ventilating the patient, we should focus on providing a tidal volume of approximately 6 to 7 mL a kilo, which for most adults will equate to approximately 500 mL. It is important to focus on slow, controlled movements when squeezing the BVM. Squeezing too forcefully and with large tidal volumes will increase the risk of gastric insufflation and lung injury. Success using the BVM isn't just about squeezing the bag. It is crucial that we can obtain measurable signs and symptoms of success. As paramedics, we need to receive real-time feedback that the patient is being properly ventilated and oxygenated, as at the end of the day, this is the cornerstone of airway management. Successful ventilation can be indicated by adequate rise and fall of the chest, confirmation of air entry via chest auscultation, ease of bagging, as well as a normal end-tidal CO2 waveform. Poor waveforms can indicate many things, including poor seals and ventilation. In addition, successful oxygenation can be indicated by normal skin color, SpO2 and heart rate. Some patients will have anatomical features that will make bag mask ventilation challenging. There are several acronyms that attempt to predict which patients may be difficult to ventilate, and one of these is BONES, which stands for beard, obese, no teeth, elderly, and sleep apnea. Let's quickly go through a couple examples and how to troubleshoot them. Facial hair and beards can make forming a good seal difficult. To overcome this, you can try clipping the beard. You can also apply lubricating jelly to areas of the beard which will be in contact with the mask. Now, this may be good in theory, however, continuing to manage the patient with hands full of lubricant is not ideal either. You can apply an occlusive dressing around the beard, or even use a very small mask to ventilate the nose while the mouth is closed. In patients who have no teeth, they also present a challenge. The main issue is that without teeth, the cheeks take on a hollow appearance, which makes it harder to form a seal. If a patient has dentures in and they are not loose, it is preferable to leave them in. If they don't have teeth or dentures in, then bunching the cheeks up is also an option. Research also suggests that placing gauze in the buccal cavities can create an even better seal. It is also important to remember that for any patient requiring airway support, especially when difficulties are encountered, that a supraglottic airway device should be considered. Devices such as the iGel eliminates the need for a handheld mask seal and lowers the risk of gastric insufflation. That concludes our discussion on airway management. Thanks for watching.